This is LiveWell Talk on vascular disease. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's. Vascular, cardiovascular, cardiothoracic medicine are topics that we have, but sometimes patients and physicians overlook peripheral vascular disease or vascular disease. So joining me today to discuss the differences and talk about common vascular disease is Dr. David Lawrence, vascular surgeon with Physicians Clinic Iowa and St. Luke's Hospital. Welcome.
Thank you.
Dave, what is vascular disease? When we say vascular disease or peripheral vascular disease, what are we talking about?
Well, specific to peripheral vascular disease, we're talking about the blood vessels in the body, primarily that are, as I explained to my patients, outside of the brain and outside of the heart, although of course the brain and the heart both have blood vessels as well, and those can have disease also, but a peripheral vascular surgeon deals with those blood vessel beds that are outside of the heart, outside of the brain. And vascular disease covers a whole range of different pathologies that can happen to those structures that can be broadly put into categories either of blockages in these vessels or of dilation or other degenerative processes to the vessels, and then how we treat them.
Well, with my work in wound care over the years, I personally believe vascular disease is so overlooked, and I think that there's a lot of vascular disease out there that is it's a very common finding, particularly if they have a wound. You're like, it's easier to count the patients that don't have vascular disease. Just how common is it?
It's extremely common. Certainly, the older you get, the more common it becomes. Once you get into the 6th, 7th decades of life, you're going to see vascular disease in a majority of people to one extent or another. And in fact, some of the atherosclerotic plaque deposition, they found it in autopsy specimens, even of people in their 20s. So it starts early. Now, it doesn't become significant in most cases for several decades, but it's just a process that occurs in our blood vessels over many, many years. And at some point, it will become more clinically obvious. The trick is identifying the problem, if you can, before it becomes a problem, and then determining the best way to manage it from there. Once you're in a wound clinic, you already have a significant issue.
Yes.
And it becomes more difficult to treat, just like any other healthcare issue.
Right. What are some symptoms of vascular disease?
Well, since you mentioned wounds, when I think about symptoms that are occurring in the extremities, and usually in the legs, this will happen from blockages that occur, and this will, as I said, happens over time. It starts with a narrowing and can then progress to complete blockage of arteries, and people will experience these in different ways, but primarily what people will begin to notice is pain with activity. That's kind of the hallmark of early symptoms in vascular disease in the legs. People will notice that they'll begin to have muscle ache with walking, not necessarily at rest, and probably not at rest, and probably not, depending on what position you're in. For example, if you're sitting or standing, it changes, but with activity. So a classic story would be someone who goes out and they walk their dog, and they notice that they're having to stop at, say, a block because their calf begins to cramp up. They stop and rest, and the cramping pain goes away. Or they're at the store or the mall, and a similar thing happens, and they begin to notice that distance becomes less and less. And that's something we call claudication. And that's the medical term we use for it. But basically, it describes that pain that we get in a muscle when the needs of the muscle for oxygen are not being met because there's not adequate blood flow getting to the muscle. And that's because there's a narrowing or a blockage in the artery that's feeding that muscle.
And so, one thing that I remember, this is probably late 90s, Plavix, clopidogrel, was only used for heart disease.
Right.
At the time. And I had a patient, had a stent placed, and he came back for follow-up, and he goes, doc, ever since I had that stent placed, and I'm on that Plavix, my butt doesn't hurt when I walk. And I was like, oh, well, you're treating your peripheral vascular disease. And, then over time, Plavix got an indication for peripheral vascular disease. So, like a
Yeah,
lot of things in
Plavix
medicine.
has been is a really important component of the medical management of what we do.
Yeah.
Regardless of whether or not we use stents, it can be very helpful in it, it is an anticoagulant. Technically, it affects platelets, as you know, but it tends to treat the part of our clotting system that is, most affects vascular disease.
Yeah. Yeah. It's a significant medication. And I think, is it getting cheaper? I mean,
Well, yes, ever since it came off its original trademark patent, and
yeah.
once it became generic, that was a real game changer because it was quite expensive initially when it was just Plavix, and now that you can get clopidogrel, it's very reasonable, and generally we don't have issues with that. Of course, there are always newer medications.
Right. Absolutely.
Yeah, yeah.
Pfizer's making enough money on the vaccines. They don't need to make money on Plavix anymore.
Well, yes. They got the
So
new pill coming out too, so.
yeah, they do. They're going to be on top of it. We talked about the symptoms and the progression of the disease, but what are some risk factors? I mean, obviously as with everything, there's a family history of it, and you
Yes.
are more susceptible. But talk about some of the risk factors for
Sure.
vascular.
Really, the big four that are common for vascular disease. Yes, you mentioned family history. That's a really important one. Smoking. Cigarette smoking is huge, and I very rarely have a patient that is not or has not been a smoker, particularly with lower extremity disease. After that, diabetes, um, and then hypercholesterolemia. Those are kind of the big four, and any one of those can, of course, dominate over the other. You may have someone that has lived as clean a living as they can manage, but they have bad family history and they have bad vascular disease, and then other people who may have just diabetes and nothing else, and that's all it took. Some people that have many risk factors and still make it well into life before they exhibit significant symptoms. But overall, yes, those are the most important ones. And certainly, as I remind people, you can't pick your parents, so you can't do anything about family history. But the other ones, and particularly smoking, that you can control, is paramount towards successfully managing these problems.
The analogy I use is a handgun, and that's your family history. And as long as it remains empty, it's not that dangerous. But then if you smoke, you have diabetes, you have high blood pressure, you start putting bullets in that chamber. Now
Yeah.
it gradually becomes a dangerous weapon. So
Yes. Yes.
keep your gun unloaded, I guess.
And that kind of handgun you can't control where it points either. So.
Right, exactly. Uh, how do you treat? We talked about Plavix, medical management. What's the next step? Plavix fails. I'm still having symptoms. What are you going to do to me next?
Well, it's interesting, and vascular surgery has been a fascinating specialty because it has evolved so much in the last 20 years. When I decided to become a vascular surgeon, I did it because I mostly enjoyed the intricate technical work of surgery and working on both large and small blood vessels. And I thought my career would be marked with long, difficult operations, with very sick patients, and certainly it still has that component, but the development of minimally invasive techniques and angiographic techniques has completely changed the specialty over that time period. And I tend to take a stepwise progression. And you already addressed, the first step is going to be lifestyle modification, medical management,
Right.
but once those areas fail, well. depending on the circumstances, of course, but we tend to try to address things in a minimally invasive way first. And what that generally involves is what's called angiography. Many of the listeners may, even if they haven't known someone who's had a peripheral arterial angiogram, many people know someone who's had a heart cath. And it's similar that way in that you use a needle to puncture directly through the skin into a blood vessel, but instead of going to the heart, we use x-rays and wires and catheters to direct devices into blood vessels in other parts of the body. Now, once you've reached the area you want to treat, for example, in the leg, if there's a blocked artery in the thigh, and you can cross that with a wire, you can use a variety of different techniques to treat that. People use balloons, people use stents. There are devices called atherectomy devices, which remove plaque by various means, either by plaque excision, or some of them grind hard calcified plaque down. And then there are other adjunctive techniques. Some balloons now have drug coating on them that is an anti-restenotic therapy that you can deliver to the vessel wall that reduces the recurrence of restenosis after your treatments. Generally speaking, our objective is to achieve inline flow from the heart down to whatever the target vessel is, and in a wound clinic, it's usually the foot.
Right.
So if we can achieve that with the least amount of intervention possible, that's our objective. So balloon, atherectomy, if that doesn't work, sometimes we have to put stents in, although stents in the heart work great. I mean, there's fantastic data on that. Stents in the leg, not so good. And the main reason is because the vessels are not static. They move a lot. If you could, have X-ray eyes and see the main artery in the thigh as someone's walking or climbing steps or getting in and out of a car, it is moving all over the place. It doesn't just stay in a straight line, and that will cause fatigue on the metal structure of stents over time, and so they fail at a much higher rate than heart stents do.
Do patients have to take Plavix after a stent's placed?
Well, yes, and after stents, they do absolutely have to take Plavix. Generally speaking, without a stent, they don't need to be on Plavix unless they have other risk factors. Once those minimally invasive means have failed, or if the circumstances, the anatomy, the extent of disease doesn't allow that to be pursued, then we move on to more traditional vascular means such as a surgical bypass. And a leg bypass or bypassing any other vessel is similar to open heart surgery, where they're doing bypass on the heart arteries. It's just that it's in a different part of the body, and there are different conduits you can use. We try to use a patient's own vein if they have a good one. That's going to give them the best outcome. But there are other options, plastic veins. We even can obtain cadaver veins from donors in situations where that's necessary to have additional options.
Interesting. What in the last 10 years, what percentage of your cases are the traditional surgery 10 years ago and now?
10 years ago, I would say in the lower extremity, probably 35-40% were traditional surgery. Now it's maybe 20%. It's certainly less.
Okay.
And we found that we can be more aggressive as we become more comfortable with these techniques. And the nice thing about the angiographic techniques is that if you do it right, you generally don't burn bridges. And if I could just put in a little pitch for vascular surgery, anytime that I'm doing a balloon or a stent, if I have to have a stent, I'm always thinking about what's the next step, because the thing about vascular disease, it never goes away. Even if you stop smoking, even if your diabetic control is perfect, anything we do will eventually fail. And that's because we can never make the vessels as good as the ones you were born with. And so I need to be thinking down the road, well, what's the next step? What's, say we do this, we get 2 years, we get 3 years, but, what are we going to do next? So I have to think about that and what my options are. And it's easier for me to think about that because, we're kind of the end operator in this disease specialty.
Well, I'll tell the listeners that I can confidently say over my almost 25 years of practice that that's a sign of a good physician, good surgeon that has a plan B and a plan C when they start to do something. And that reflects well upon you, Dave, because those are the good doctors that are thinking ahead. Okay, what is the next step? What do we do if this doesn't work? What's our plan B? What's our plan C? You know, um, when people don't have a plan B, they can get in trouble real quick. And I think a good physician, a good surgeon, which you are, they have a plan B. They have a plan C.
Right, and it's interesting. When I would talk to some of the older surgeons, many of whom are retired now, you see that things that we could do in, say, the 1990s or even the early 2000s were going to be adequate for these patients. But overall, people are living longer. And
Yeah.
so maybe you could treat a vascular disease and expect an outcome for a given period of time, but a patient's life expectancy was such that it didn't matter as much. But now the demands that are placed on this are greater. So we're constantly searching out new and better ways to treat these problems that are going to be more durable as people live longer. We also want them to live better.
Right, right. And I can say over my career, I've seen changes in the fact that like just pressure ulcers have gone down when we started to understand the physiology of pressure and the injury it can cause on a patient, bed sores, right?
Hmm.
I mean, when I was a medical student in, the mid 90s, there was 2 or 3 pressure ulcers on service all the time, right?
Yes.
I mean, you were debriding them, and now, it's rare to see that anymore. It's very rare, which is great. And you don't want to be a victim of the tyranny of the anecdote, but I definitely think there's less amputations on the service than it was 20 years ago.
Yes,
You
I
know,
would agree.
these are all good things.
Yeah.
Well, this is really great information. Thanks so much for taking the time to talk about this. Again, this was Vascular Disease with Dr. David Lawrence, Physicians Clinic of Iowa and St. Luke's Hospital.
Thank you.
Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.